Buenos dias. That's all I know. I hope that it'll be okay that I'm going to speak in English. So it is a pleasure to be here today. My name is Christopher Still, and I am but I'm not a surgeon. I'm an obesity medicine specialist, an internal medicine guy that's been in the field of obesity for almost 30 years. And my prime interest is working with the pre and post medical management and problems and successes, mostly, of bariatric surgery patients. So I'm honored to be here today. I'm been asked to talk about genetics and bariatric surgery and their predictors' outcome. I am by no means an expert in genetics. I think that it has a very powerful background to the disease, and we've done some work in trying to predict postoperative outcomes, and I'd like to present some of that data today. So we all know that postoperative weight loss is very variable. And there's people that do well, there's people that lose a lot of weight and keep it off, there's people that lose about 50% of what you'd expect, and then there's people that don't do well, don't do as well as we may expect. And so obesity, and specifically bariatric surgery, there's a caloric restriction that ensue. There's changes in gut hormones that I think are very important. There's intestinal peptides that change. There's absorption, and those influences are either normal, high responders, low responders, but there's also this background of epigenetics, gene expressions, microbiome, which I think is a huge area of opportunity to look at. But today we're going to look at the genetics and the genetics background. So can genetics improve our predictions about surgical outcomes? So I just want to give a little background because I'm not sure everybody's familiar with genetics. As I said, it can be very complex. But the genome is like a book. And if you look at a book, it's just repeating these sequences. And so this sequence is called "The Sky is Now Blue." So if you take a book and make copies and copies of it, over time, lost in translation is a good example for me in Spanish, there can be some slight variations. And those are called SNPs, or single nucleotide polymorphisms, or variances. And so if you say that, no, right here. So you can think of this genome as just repeating these normal sentences. The sky is blue. So if there's a slight change in it, say the sky is now blue, that's just a simple SNP or change. No real big difference. You still know the meaning of the genome. The sky is now blue. There again, a misspell, but you understand what it is. Really no big change. The sky is now blue. So these are all what we call single nuclear polypeptides, or SNPs, that are hugely variable in patients in the disease of obesity. But if you change something to say that it is very rare, but the sky is not blue, that's a huge change, okay? So everybody's different. You get out umbrellas, you place your day differently. So that is a rare variant. So the difference when we talk about obesity and its predictions are these common variants versus rare variants. So if we try to identify this, so this is effect size here, and on the x-axis, allele frequency. So when we look at these rare variances that have very small effects, and then effect size. So these are things like PCSK9 for cholesterol, cystic fibrosis, the BRCA gene. So very, very rare, and they have a significant effect size. And then you go up to the more Mendelian disease. So these would be the leptin deletions. So these are very rare, couple in worldwide, but they have significant effect size. For better or for worse, when we look at obesity and the traits, they're more of the common SNPs that have very little clinical effect. And so the more you have all these SNPs, they have more possible influence, but the good news is they don't really have a clinical change that we see. And so you can see the common variants, which are most common, are about 1 to 5% of the population, which is not trivial, but the rare variants are very rare, 0.1 to 1% of the total population. So when we look at obesity and genetics, we started back with the candidate genes in leptin. Leptin is a protein that's produced in the fat cell that goes to the choroid plexus of the brain and affects appetite and fat mass. So that was discovered back in 1994. And then we had these other candidate genes. So there was the leptin, LEPR mutations. So that was back in the first part, back in probably about 2005. And then we were able to look at the whole genome, and we were able to survey the whole genome, and those were called genome-wide association studies. And that was the first FTO. That was the first common variant gene that was discovered. And then since then, we're able to do whole exome sequencing, and this looks at when there's actually a change in the protein itself. So when we look at the history of obesity and obesity genes, we started with these SNPs, then we went to GWAS, and then we went to whole exome sequencing. I'm just going to walk you through now the things that we found in these three major categories. So these are these obesity SNPs that I was talking about. They're very common. So there are many different focuses. So some are more predominant to BMI, and that is mostly true to FTO and MC4R. There's some that are initially thought was just waist circumference and waist to height, and there's also a waist to hip ratio, and there's also these SNPs that were height specifically. But those was just in the beginning of what we see. So there's probably 25 to 30. But as we know now, there's hundreds of these common SNPs. And some of them are more effective with fat mass, some waist circumference, the extremes, a lot of them on BMI, a lot of them on BMI and waist to hip. So all of these different SNPs, if you will, can, in a small way, affect the genetic trait of someone with obesity, if that makes sense. And just think there's a whole host of all these SNPs for every disease that you can imagine. So to give an example of the effect size of these alleles, this is a paper that we published just looking at 5 or more alleles. So we just looked at 5 genes, and so there's a possibility of 10 alleles. And you can see the excess body weight between 0 alleles and 5 alleles was really not that great in the big scheme of things. So we were not able to predict obesity just based on allele burden because of these common allele variants. So then we said, okay, if we take the most common genes at that time, so this was MC4R and SIG2, FTO, and that LEPR5, and we looked at those, so there was 5 genes with a total of 10 alleles total. We looked at those with regards to weight loss after gastric bypass. And you can see here that we had people individually lose weight, and there was really no difference in the genetic makeup of individuals that could lose weight with medical management. But at the time of surgery, you can see there was individuals, and this is very important because this above the line here is individuals with BMIs greater than 50. And these are individuals with BMI less than 50. It did appear in individuals with BMIs less than 50, the allele burden had an effect on not only weight loss, but on weight maintenance afterwards. And that was initially reassuring because if you could genotype these individuals and they had a low allele burden, then we were hopeful that people would lose weight and keep it off over the long term. The problem is we found that these individuals with the BMI greater than 50 had a lot of those rare variants overriding the common alleles, and they really overpower that. And that's what's really driving a lot of obesity is these rare variants that we don't have a good handle on with regards to clinical prediction. In addition to our study, there was a recent study done in duodenal switch patients that also did very similar things of taking these different various SNPs, and lo and behold, they saw the same similar thing, small differences, but not great differences clinically with regard to SNPs and SNPs analysis. So then we said, okay, let's do a genome-wide association. So we took about 4,000 patients that had gastric bypass, and we did genome-wide association studies. And we were first to do it in bariatric surgery. Lee Kaplan came 1 month after, so we were very happy that we were the first. But basically, rather than looking at a specific SNP, we wanted to look at the whole GWAS to see what alleles were associated with sustained weight loss after 2 years. Dr. Kaplan looked at the nadir weight loss at about 12 to 18 months. So they were slightly different, but we did see some SNPs that did stand out, but they weren't really clinically significant for long-term weight loss and made a big difference of predicting after weight loss. And then these are the most common SNPs. They don't really illustrate very well, but there's a whole host of these common SNPs that everybody has. One that Dr. DiMaria commented on that I'm going to focus on a little more is this MC4R, because that's pretty common. It's about 5% of the population, which is not insignificant. And I think it may have a role, maybe not with predicting primary procedures of bariatric surgery, because I think weight maintenance and obesity, after you lose weight, weight maintenance is a different disease, if you will. And I think there may be different treatment modalities for after you lose weight by any treatment modality, bariatric surgery primarily. But there's some work with MC4R. So then finally, I just want to show you that we're doing this whole exome sequencing. So this is the most up-to-date, if you will, looking at sequencing. And whole exome sequencing is looking at variants of protein coding in the region. So it actually affects the protein. We have a collaboration with a biotech company called Regeneron. And basically, we're doing whole exome sequencing on our whole health plan. But what we did initially is we took our 5,000 bariatric surgery patients, and they did whole exome sequencing on those individuals first, because they were so well phenotyped. We had them well phenotyped. And so if you look at whole exome genotyping on Roux-en-Y gastric bypass, we looked at nadir weight loss. And you can see there were just a few of these rare variants in whole exome sequencing. And they're very, very rare. I mean, less than 1%. So they're not very helpful. And then we said, okay, is there any way we can predict who's going to remit their diabetes and who's not due to whole exome sequencing? And unfortunately, there were very few. There were none, basically, that we could predict. So we thought, okay, in those rare variants and in the common, we said, well, the most common in the population that would affect us clinically are these individuals with the 3 to 5% with severe obesity. And as Dr. DiMaria alluded to, they generally have direct influence on this leptin melanocortin pathway, which I think is really important. And that's something that we, as clinicians, may be able to modify. So the various rare genes that can have large effect sizes, as I said, are leptin, LEPR, POMC, PSK1. But you can see they're very, very rare. Diagnosed in fewer of 100 patients worldwide, 2 to 3% of the population, fewer than 20 patients worldwide. So very, very rare, but they have the most high effect side. And you all know the example of leptin deficient individuals or kids. You give them leptin and they lose weight and they increase their energy expenditure. So we were interested in this more common of these 3 to 5. And as I said, I just want to focus on this MC4R. So this is the pathway, the leptin melanocortin pathway. So you have adipocytes, as I said. Leptin is produced by the fat cell and it goes to the choroid plexus of the brain. And this is where you have the POMC, and this is the MC4R pathway. So I just want to give you some background, is that we're doing a study with a pharmaceutical company looking at trying to antagonist the MC4R receptor. So this is called setmelanotide. It's in phase 2 trial. And basically what happens is that this, so here we are with the leptin and fat cell. In a rare variance, there's a blockage here. So they have no satiety, so they have increase in hunger. And so what we want to do is try to look at this targeting the leptin melanocortin pathway. So as I said, this is the same thing that I just showed you, but this is where we want to focus right here, is this MC4R activity. And just to give you a little background, is the medications that are on the market today, they're all centrally acting except for orlistat, but they affect this leptin melanocortin pathway. So there's phentermine, bupropion, fenfluramine, which is not available now, but you can see they affected POMC, There's the lacarcerin, which is the serotonin. Those all affect here in POMC, all trying to affect this MC4R pathway indirectly, though. That's the problem. It's very indirectly, and there's other circuits that can circumvent them. So the novel thing about this is that this medication is actually looking at targeting right here and skipping all this part, the circuitry, if you will. So this is setmelanotide. It's a polypeptide developed by Rhythm, and we're in a phase 2 trial. And just to give you some background on it, it is looking right now at these rare but more common genes that we see, about 3 to 5% in the population. And I'm just going to give you an example of 2 patients that are on the that were in the trial. Significant weight loss and significant improvement in glycemic control. So, and this is, we just started this. It's an injectable every day. There's a lot of titration and things. But this is a second patient, also a very significant weight loss and improvement in their labs. But MC4R, as Dr. DeMarias talked about, is very important because it affects hunger and satiety, and it's relatively common. So in this trial, they're just looking at those rare variants. But I think that even though this may just be initially approved for those rare variances, after bypass or after bariatric surgery, it may be a good adjuvant therapy that may be more important or more beneficial or better than the medications that we have today, going right to the target of the satiety center itself. So in conclusion, obesity traits are made up of more common variants which have mild to modest genetic influence on post-surgical weight loss and are not as clinically significant. The rare variances are very rare but have the most significant effect size. MC4R appears to be the most clinically relevant of those common variants, and new pathologic treatment may enhance that MC4R activity to help not only with weight loss, but also as adjunct treatment in the bariatric surgery patient. Thank you very much for your time, and as I said, I appreciate the time to talk today.